All right, good morning, everybody. My name is Elaine Harkins. I'm the ADRC Director here at Legacy Link. Thank you all for joining us this morning. We will be hearing from Miss Libby regarding advanced care planning. So just a few things about her. Libby Dunahoo is the manager of the Advanced Care Planning Department of the Northeast Georgia Health System, which serves 19 counties through 4 different hospitals and over 70 multi-specialty provider networks and a GME program. She has a BA in psychology from GSU with over 20 years of work in advocacy, development, and affiliations at Emory, as well as a statewide adoption agency. She started her work at NGHS in 2017 to implement the community initiative of Respecting Choices, which you all will hear today. She is passionate about empowering people to have a voice in their healthcare through their advance directives. She advocates that advanced care planning is a wonderful gift to your loved ones. Libby is a local member of the Beyond Dementia Coalition, North Georgia Senior Resources, and Commerce Club of Gainesville. She actively participates in the Northeast Georgia Health System Ethics Committee and the Emory Ethics Consortium. In 2019, she was a Community Wellness Award finalist for the Gwinnett Chambers 2019 Healthcare Awards. Please help me welcome Libby.
Okay, so I'm a loud talker, all right? I'm just going to...
Sorry guys, let me just say one thing. This is being recorded, so just FYI. And if you need to use the restroom, they are out the door to the left. Thank you.
Tell me if you can hear me. Is it bad? Are y'all good? Okay. If you can't, I'm more than happy to use your microphone. But I also know that because I'm a loud talker, I'm going to find myself needing to quiet. So, thank you. Okay. So, before I get started, you've heard that I'm with Northeast Georgia Health System, but let me just put in a plug for ACAP. The point being that if you guys have not seen the other presentations that we've had for each month, please go on and listen to them, because what you're going to hear me say is a lot of stuff about talking with your loved ones, talking with your loved ones, talking with your loved ones. Conversations are more important than documents, okay? The point being that everybody that's come forward with their presentations has also highlighted the importance of that in different areas, whether it's for our senior center, with Glasgow, whether it was with Dr. Safer talking about behavioral health. There are so many great resources, so please utilize the ACAP website and look at the other presentations if you have not heard that. So, like I said though, I'm here because I'm talking about this. We didn't start the program itself. We contacted where it came from, out of the process of Wisconsin, government health system. Why did they come respecting choices? We in the health system are called respecting choices. But guess what? We cannot respect choices if we haven't made them. Right? That's the number one thing we see. The biggest thing we see is how do we, let's see if I'm pointing in the right direction. Okay, there we go. Let's go back. Okay. We're trying to empower people to take charge of their own health rather than being passive recipients. Think about healthcare. People think that I'm going to come in and my grandmother was that people that had taking things over questions. And I'm going to say yes for you. Right? We have to advocate for the people that we love. And sometimes those people are intimidated by the health system and say, oh, don't advocate. Don't have. Yes, I work with the health system that say, please ask questions. That's why we're doing this program. The whole point is that we're supposed to be respectful and responsive to what the patient's goals, preferences, and values are. Think about it. A patient's goal, their values, their preferences are going to be guiding clinical decisions, not the other way around. But too often we see people do the way they can. Right? You tell me what my options are, and then I'll go from there. But you go from saying you're the expert of your life, and you come to the health system for medical expertise. But you're the expert, so you have to really bridge these two things. So you're going to hear me say over and over and over again that the conversation is more important than the document, because I'm going to advocate for you to start a conversation about death with your family. And you're all like, what in the world? No way. This is exactly why our culture doesn't talk about this. How do we normalize this? We normalize a conversation about death because it changes how you live, not because it changes how you die. But it will change how you live if I can normalize getting you guys to start talking about it soon. And that's exactly what the recovery program realized. Was we wait when people are in a crisis in the hospital and we say, let's start making decisions. Wow, things. We talked about this. We need you to allocate your loved ones in life-saving treatment. I want you to talk about it. Let's talk about it at the screen. Let's talk about it while you're healthy. So in the culture, we have to find a way to get comfortable with that. We have to find a way to say that it's not negative to talk about this. It's positive to say, I want to change how you live, but you can't change how you die. All right? So, it's all about empowering people. Knowledge and power. That's a big piece of this. People don't know what their choices are. People don't know, how do I, what do I do? So, knowledge and power. That's really important in this. I love the Nelson Mandela quote that says, may your choices reflect your hopes and not your fears. Think about healthcare choices. Very often, healthcare diagnosis comes with a lot of fear. What are my next steps? What's happening? What do I do? What are options? But you want your choices to reflect your hopes, not your fears. You don't want fear to drive it. So, again, it comes from empowering people. You will hear that our payer system is moving towards value-based contracts, and you're going to hear when you're looking at healthcare choices, your insurance is going to tell you about all these value-based options that they have, right? Because what insurance is doing is that healthcare and insurance are all treating people like their disease. And now they're all trying to go, well, wait a minute, we really need to see the whole person. Because it's very much like the old adage of if you want to hold a bunch of people to get them to all of a sudden identify an elephant, that's what they're doing. That's what's happening though with the healthcare system. You've got your PCP, you've got your cardiologist, maybe you've got a PT, maybe you've got home care. Who knows what's happening to you? And do all of them know, well, this is that patient? This is where your advocacy has to step in and say, okay, I'm the whole person. We need the health system to be treating the whole person. We need for you advocating for the whole person, right? When you're seeing someone and it's affecting, if your treatment is affecting your ability to buy groceries or food, what community services do you need? What is it? Do you know how to ask for home health, home care? Do you know the differences? Do you know what kind of care is? Do you find every time that who's advocating for the whole person, for the whole person of care? So, healthcare is much more than a diagnosis. The greatest source of stress when they did the Patient Advocacy Foundation did this study. They said, what is the greatest source of stress when you get a diagnosis? And none of those things were about the diagnosis. People worry about what access do I have to care, right? People worry, what about the finances? Am I going to be able to afford the care that I have access to? If I'm going to put my family in financial and medical debt. Medical debt is the highest rate of bankruptcy right now. Understanding. I don't speak medical speak, because you've got to remember that in that person-centered care, everybody has a right to understand what's going on with them. So when you go into healthcare, part of it is advocating for understanding your own healthcare choices and what's happening to you. So we're always telling our physicians and reminding them don't speak medical speak, and don't talk down to people because they don't speak medical speak. Everybody has a right to understand them. Voicing my values. People always say, I'm conditioned to talk about my condition. I'm conditioned to come in and ask to only talk about my diabetes, and that's, but remember the whole purpose of care. Are you having food insecurities? Do you need help at home? Do you need respite care? What are the things that you're thinking, I don't know, I don't think for my medical team. So we need to remember that that's all for people. And then just all the other resources that it touches. Because it does touch transportation, it touches, food insecurities and rent and all the things that go along with healthcare. Much more than the diagnosis. So advanced care planning becomes something that starts breaking down these barriers. Because what it is, I'm saying that advanced care planning comes into play with completely Advance Directive, which is about identified care. Remember, this is all about upstream from that. What this is about is saying, okay, we need people to start talking about quality of life sooner. Start talking about quality of life before you're looking at end of life. Because in order to advocate for quality of life, it needs to be much sooner. It should be years-long process instead of just last couple months, right? We have over-medicalized in our culture. We think of it as a medical process. It's not. It's a human process, right? If you have walked with someone you care about to the end, it's a privilege to be a part of that. I tell this to all the physicians and nurses that I go to cardio training. Like, you know what? People get into medicine, want to help people, and give people. That's an awesome thing. But guess what? Every patient you have will die. All of us are going to die. So, if you count it as a privilege to live with someone to the end, it can help ease this conversation about I want to be able to advocate for you. I want to be able to make sure that I know what your quality of life is and what I need to be finding out to advocate for that. So how to advocate is the next thing. Medical rationing and social marginalization. Often because our health system is kind of a place where people don't access. And it comes from things that we don't know. So advanced care planning comes from saying, we want you to tell us what you want because we want to be sure that we're doing what you want. That it's your right, your choices, because of us having the group of things that we've done in the history. And we need to understand that people have this choice because of that. So I'm trying to empower people to say, yes, tell us what you want. It's not my choices for you. It's what do you want? What do you want to advocate for your loved one? Caregiver isolation is a very real thing. We end up seeing people a lot of times these long disease. Alzheimer's is being just a couple. But in that long process, what does the caregiver need? That isolation becomes a point of, oh, I'm going to an appointment. I have to get in there. I have to do the rent, the transportation, the food, the care, and it can be wearing. It comes to the process that if you start knowing how to ask for help, knowing what the patient needs, knowing what the caregiver needs, this is a part of it. This is a part of that upstream how to ask the right things. Because, like I said, this is about your healthcare and patient autonomy that you are the expert of your life, and I continue to say. But you're there for medical expertise. You're not there for medical expertise, right? So the point being that when we want to merge your expertise and that medical expertise, it's for us to say we want your goals and your guidance, your clinical decisions. So, why do we know this is important? Because people will go to great lengths to tell you what matters to them. And we can't legally act on a tattoo. But it shows that people have some pretty strong opinions, doesn't it? Right? People care so much that they're like, I need to be sure the health system will hear me. We can't. 90% of people will say that movement is important. You guys are sitting here not ahead of me and go, I know this is important. But yet only 27% will actually go do something and actually will get a conversation, actually put something in writing, actually initiate it. Because we all know it's important, but it is a hard conversation. Don't diminish it because something is good, it should be easy. It's hard. It is hard. And it's a cultural norm that we struggle with this. So it's hard to say, okay, we're going to start talking about this with my family. And there's some pushback. Boy, hate when I keep talking about this confession. They tried it, they're like, oh, I'm like, no, really. Remember? Now we're going to use this. And guess what? Let's talk about it again. Let's talk about how we advocated for her. Let's talk about what you guys are advocating for me. And it frustrates them. You can't even do it. And you know what? One day they're going to appreciate it. Because one day they're going to. Because, like I said, if you've been on this has the privilege of walking and someone, were you able to feel like you honored your wishes? You know, I think that that's a very special thing. So this is how we do it in our health system. Everybody has one of these folders in front of you. Like I said, we're pulling folders back into it, but you'll notice that that's on the back of the folder. Because that's what the health system is supposed to do. Everything inside the folder is making choices, because like I said, we make them. So everything that we do patient facing is encouraging people to make their choices. We also encourage people in understanding about the pulse. Show of hands, has anybody here heard of a pulse? P-O-L-S-T. Okay. So that's a condition order for life-sustaining treatment. That's for those people that went to the lakes and having DNR tattooed on them that can't be followed. A pulse is a portable medical order. So it allows people to be a DNR outside of the hospital for a very specific subset of people. But we want people, again, education, knowledge, power. So it matters for people to know what that is. And then community tool is the plan in the can that I also have in front of everybody. This is the tennis centers, like the colleges and high schools, are donating tennis cans to us. And that's because when I started at NGHS in 2017, so did Dr. Kruer, who was one of our internal medicine heads of our new residence program. And he came from a place in Michigan that did this because they said every time you come to the hospital, they're going to ask you if you have an advance directive. That's part of our accreditation. That's part of the Patient Self-Determination Act, that we have to show that we care about your choices. So we're required to ask you every time you come if you have an advance directive. And most people say no. Most people go, what is it? I don't know. I'm not dying. I don't need it. You know, a million reasons why it's no. We want you to have it. We want you to have it with you. And especially if you come to the hospital in an emergency. So the biggest thing we find is that people say, you panic when there's an emergency. So you go ahead and have this ready. This is that grab and go in an emergency toolkit. It's like packing for an emergency. You put your advance directive in there. You fill out the medical form and patient medical history. You put in the glasses that I can't see anything if you have to read it without these. You put in a phone charger because during COVID, we found that people would come to the hospital in an emergency, tap their phone, but then they get admitted, and all of a sudden that phone becomes a paperweight when it's run out of battery. So, you know, the things that people want to keep, this is the other thing that we give out with this. And the reason being, because this introduces this conversation. So when I tell everybody you should be talking about this, and they're like, oh, really, I didn't bring this up with the family. It's like you do it through this. Hey, if I were an emergency, I'm going to fall. If they found me at home, call 911, they got coming. If I go to the hospital, you need this to go with me. If I go to the hospital, I can't speak for myself. You need to be sure you know how to speak for me. So that's why we pair that together. So we really start off with, when we're talking to people about the education, is making sure that we're all speaking the same language. Because healthcare has its phone language, you guys know thing. If you know your own healthcare that you're dealing with, you know all the legal directives, right? With advanced care planning, I told you over and over again, advanced care planning is just a conversation. I'm just saying I want you to start talking to the people that you like. And so that's all it is. The document is the Advance Directive for Healthcare. Some people don't know what that is because the Advance Directive for Healthcare used to be called the General Attorney for Healthcare and the Living Will. More people know that language. Oh, I have a power of attorney. Is it a power of attorney for healthcare or is it a financial power of attorney? Which is probably why we got away from calling it durable power of attorney for healthcare because people were confusing the two. They're separate. One of them is for healthcare choices, one of them is for your money. And the living will. What do you want to request? What do you want to refuse? But because they were two separate documents in 2007, our legislature combined those into one and here's your advanced directive for healthcare. Now, if you want to document it, you need to update. You can do another one. Don't ever feel like you can't change your mind. You can change your mind and do another one. We do remind people, though, that it is not a financial will for your financial power of attorney, and it's not a will for your stuff. So don't go writing in your advance directive that, the daughter gets the earring, the son gets the car. That doesn't matter, right? But the important thing that I really stress to people is the reason those are not a part of your advance directive and that they're separate is because there's no people that do stuff. And guess what? We serve a lot of patients that don't have stuff, that don't have to have a financial attorney who will. Everybody has a right to their health insurance. Everybody. So it's really important for us to say that the legislature did this so that you can complete this without going to an attorney. All right? It's also not a behavioral health advantage program. That's something that I put out there that anybody needs to ask me about. Anybody gets a behavioral health diagnosis. State just back its pediatric advance directive last year. So if that's something that you want to know about, that is specific for behavioral health. And I can tell you more about that. So I want to show you what we have inside our folder. So there's a few things that I want you guys to be able to actually use these resources. First off is the green brochure of the big green link on it. I'm telling you that this is the hard presentation, so I'm going to just give you a way to talk through it. There are questions that you can answer. Hey, let's talk about quality of life. Hey, what are the fears that you have about healthcare? Remember, we want your hopes to drive your choices, not your fears. What do you fear? People can tell you that. Tell me what experiences you had with a loved one. A lot of times your own experiences inform your choices, and you don't even realize that there's choices out there. It's really important to find out the experiences people have gone through themselves, so that you can then show them and talk about how it could be different from your mother's death went, and how it could be the same. Something that you found positive, right? But I think that it's really important that, there's all the language in here that helps you understand what the healthcare reason is. It helps you understand the lingo of what things are. But I love that it gives you questions to say, hey, I know this is important. I don't really even know how to talk about this. Will you work through this virtual with me? Help think about if I needed for you to advocate for me. Okay, this one, setting healthcare goals. You got this from the VA. I love what they did with it, because this is education about risks and benefits of life-sustaining treatment. If someone's going to have to advocate for you, they're probably making decisions for life-sustaining treatment. So again, knowledge is power. Again, it's important for people to know what they're choosing. Don't just go by the fact that, the medical team says, absolutely, yes, here, we'll get you down for a training and tech and long-term analysis and this and this bunch of lingo that they're throwing at you. Okay, tell me what this is. I'd really like to know what the benefit is, right? That this is a unbiased document. That I'm not telling you should choose one thing or another. I'm telling you that you have the right to choose, so you should know that there are risks and benefits to everything. I would say that something that we find very often is that because we're not trained, that people don't, they get a lot of their information from TV, right? Well, I would say that CPR, but you have to work with people to help with you. That's the big misconception is that that's not what CPR is trying to. And if you've seen CPR in real life, sometimes they look at it's not anything that people see on TV, but if you make decisions based on something like that, then it's been a disservice for you because you don't really know what you're advocating to someone. We had someone in the hospital who was in her 90s. When we were talking to her grandchildren about what she wants CPR, they were like, of course, and they were incensed that we would even ask. Like CPR was taken in her heart, of course. Like, how dare you even ask that? And the heart, and then the folks, and then the grandchildren yelled at us because we were later. And it's like, okay, so what we're trying to do is educate people. It's your choice. Advocate for your family, absolutely for what they want. I'm not going to choose that for you. What I'm saying is know what you're choosing. Conversation. This is the biggest thing I can do. People can tell you what they want. People can tell you what they feel about them. They might not put it in medical terminology. They might not know if it's in place in the treatment. But they can tell you what they want. So then I challenge them to take that to your medical team and see how it's translated to what you're doing. So this is really important. Then we actually have an advance directive in here. Oh, you. Good choice. That's okay. All right. So then we have an advance directive. Now, I'm going to tell you that this is not the Northeast Georgia Health System document. There is a Georgia Advance Directive that is complete Georgia statutory language. And I will tell you that everything that does Advance Directive in Georgia, if you're not just going to do Georgia 1, it needs to be what's considered substantially similar in order to be able to complete it. And so this is something that when we started the Respecting Choices program at Northeast Georgia Health System, we worked with our attorneys. Because what we said was, they don't need to go right to complete this, but the Georgia one is a lot of legal fees. And we serve a community that we want to be sure that we can offer something that's at fifth grade reading. I think it's important for people to understand that you're going to be able to have the right to work through themselves and what they can hear for them. So, this is good in the state of Georgia. It's not just for our health system. I'm telling you that we did this because we wanted to take the part that we needed to have statutory language from the legislator, but also make the choices easier for understanding. So, the first part in the advance directive, page 2 really just goes for explanation. But the first part in any advance directive is naming your healthcare agent. So remember that was placed in Bureau of 30 for healthcare. This is where, you're naming the person that you want to be your advocate, right? And it says, just because I know what I said does not mean I know what you told. This is what we deal with a lot. We think that, oh yeah, I told them, they know what they're good. They know. And then we come to their person and they go, yeah, we've never talked about this, and I don't know what they think they're saying, but well, we got to get y'all on the same page, don't we? So when you're talking about naming it a healthcare agent, the reason we do this is because everybody has a legal medical surrogate. We talk about legal next of kin, but that's a thing. In medicine, it's called legal medical surrogate. That's who's going to speak for you if you can't speak for yourself. Everybody has someone. We legally have to go through this list of it's going to go, if you're not advocating for yourself and you haven't named someone in an advance directive, then we're going to go by your spouse. And guess what? Marriage does not count in that. So for all the people that go, oh yeah, we've been together 30 years, I'm like, they don't have rights to make healthcare decisions. You want to name them, do an advance directive. But don't assume that legal spouse being legal medical surrogate thing. And also, significant other, you have people that say, oh, comment on there before, oh, this person comes in and they get to be a patient rep and come into my room and visit me and hear what the doctor's in there, patient rep, right? So spouse, adult children over 18, consent to that. So tell me for anybody that has your ordinance. Therein, I'm not saying that your children can't discuss together, but needing to name the one voice. Who's the one that would be next to advocate here? And then you can name a backup and a backup, right? After adult children become parents, after parents become siblings over 18, as well. So, and beyond that, you go on down to the surrogate order and you go into nieces, nephews, things like that. Those people can make decisions for you around decelerating care. They can't make you the end. They can't make certain decisions for you. So we need for people to understand what those rights are for a legal medical surrogate, and then know, hey, you can name who you want. If you don't want us reaching out to that strange children and your significant others who you want, you need to name them. Because we don't have to speak to them. So it should be someone over 18, someone that you trust, someone that can make decisions in difficult times, because if it's someone that, you know, then it is a tough time if you're not advocating for yourself, right? But it's someone that you have to trust and make that will honor your wishes even if they disagree with them. So that's, I would say, something we see a lot within the health system is the disagreement of the people that are visiting the patient. And we're going to figure out who should be listening to. And if you haven't done this, we need to hear the person that's going to honor your wishes. So choose that right person. And then, like I said, you can go through and you can name someone, you can name a backup, and you can name a backup. But it is, if that person's not available, you can name someone else, say they can't take my phone. We will say, if someone's not available and we have to go to the next one, and if you didn't name another one, then we go to that legal medical surrogate order. Like people that have been taken name from incarcerated, you might get your right to do that, but if you're not available 24/7, we're going. So just things to be aware of. Page 4 is what I love, because every time you tell someone they're going to be your agent, I'm going to tell you what authority that is. It's like, okay, so what does that mean? Make me your health agent. Well, here you go. Here's the whole point that made it very simple. This is what your rights are as a health agent. You get to, authorize, you get your consent, you get your request, refuse, you can make contracts for me. Doesn't make you liable to pay for my care, but you can make contracts for my care. I'm trusting that we have a good conversation about what I would want and how you're going to advocate for that. But then it said only courts can remove this authority. So if you name someone, and we want them to be someone that's going to honor your wishes, if they're not, only the court gets to remove that authority. We don't. So we have to listen to that person until the court gets involved if it's being determined that they're not following your wishes, right? And then comes the statutory language. After that, there are certain rules and authority that your healthcare agent gets to do, but that you get to limit that authority. So if you're telling someone, you're going to be my person, you're going to make my decision one-on-one, you have the right to make decisions after I'm dead for autopsy, body donation, organ donation, and final disposition of your body. Those are things that some people will go, well, you know what, I'm good with that. I'm not paying for me, but I'm going to have to wait. I'm not going to Some people will say this is limited, and I don't know, they can't make decisions about autopsy, organ donation, or final disposition. Example, several people that have named a significant other as a healthcare agent, but then they'll go, but final disposition the son's going to do that because he doesn't have human arrangements or something. So does that make sense to y'all? Okay. And that's why there's lines next to that one, because you can limit someone's authority and say, well, they can't make decisions about autopsy or organ donation or something. But if you're going to tell them they can't make decisions about disposition, well, we have other conversations. So that's where you can't just limit their authority and not give us anything. Otherwise, we're stuck with more knowing where to give you. So, that, my friend, is all part one. That is the most important thing that I encourage everybody to do. The most important thing in an advance directive, naming your healthcare agent, having that person, having the conversation with that person so that they know that they're advocate for you. That's the most important thing that I encourage everybody to do. Now, we go on to part two. Dr. Wanda, you read this book, Being Served. Fantastic book. Highly recommended to everybody in this room. Please, please, please read that because that will also encourage you. You read it, conversation with people that you love. Because he does an excellent job of having you in as a medical physician and also how everything changed when he was advocating for his parents. And he became a son talking about mom and dad. It's a beautiful story. You may not control life circumstances, but getting to be the author of your life means getting to be told what you do with them. I love that he really is the one kind of author of the whole point that we don't get to control how we die, and it's all about how we live until we die. So part two becomes that part that replaces the living will, right? This is your treatment practices. What do you want to request? What do you want to refuse? And I'm going to remind you that in this method, the very first paragraph of all practices advance directives reminds you that if you name someone in part one, if you name a healthcare agent, you have given them authority to make decisions for you. So therefore, these things become suggestions. This should be guiding their care. However, you can choose to be doing something to your loved one that isn't exactly documented here. And we're going to listen to you as a healthcare agent. So remember that point that I said in choosing a good healthcare agent, choosing someone who will honor your wishes even if they disagree with them. Then you come from the place of saying, then we're listening to your healthcare agent. So make sure that they're making the choices you would want. It's broken into two parts. The treatment choices are broken into what would you want in a terminal illness, the long-term thing you see coming. We have a lot of people that, whether it's cancer, Alzheimer's, something that is a long-term, they'll say, really felt too early to talk about this. Late, and then we couldn't talk about it. We couldn't have a conversation with the people, and now it's really hard because it's hard to advocate now. But with the long term, we've had a lot of people say, I just want to be heard, and we're doing everything we can to keep them comfortable, right? This is the long practice that we're going through. I know a lot of people don't know about palliative care. People are like, what's the difference in home health and home care? What is palliative care? How does that apply to hospice? Well, hospice, I know that you're not actively fighting your disease, but I remember saying, palliative is symptom management before hospice. You're actively fighting whatever it is that you're going through. But again, advocacy comes in, and sometimes I'm telling people, we have so many good programs that are really all focused more towards starting with this quality of life much sooner in the disease trajectory. But the other choice is stage permanent unconscious. So that's the emergency room. That's the car accident, the ACAP, the stroke, and all of a sudden, oh wow, okay, now I have to make a decision, and there was no long-term complications coming ahead of this, but now I have to be able to advocate for my loved one. So the point being that the choices underneath those are exactly the same. Everything from do everything, extend my life as long as possible, using everything you've got, to allow my house to keep me comfortable, but don't do anything else. And anything in between. So we're talking about a huge spectrum of things that you can't find in every situation you can find yourself in. When we go back to the conversation, more important, when you know what quality of life means to someone, it will help you understand whether you're in the terminal illness side of watching them through their journey or the sudden event. Do they want everything? Do they want nothing? Do they want something in between? What is it that you're advocating for? So those choices, and there's even lines underneath that you can customize it as much as you want. I've had people ask me, can I put a time frame in there? And I say, I'm dealing with cancer. I want to know that I'm going to be comfortable. If I'm in a car accident tomorrow, I think cancer's taking me out. If I'm in a car accident tomorrow, I find myself in the ED, can I say that I have to request everything, but only until my son can come from our country, and then I want him to remove care? And my son, you know what you want? Yes, let's put that in here. Let's make sure your family understands that. Yes. Yes. Yes.
There's also been factor choices been put into
Yes.
care providers what happens to this.
Yes.
Is a care agent is not really follow the individual perspective, then they can decide to follow the wishes of the individual.
But a health system is required, if you have named a agent, is required to listen to your agent. It can spark a conversation where we can say, do you need me to repeat the question? I just thought you stand, I thought, oh, I'm just yeah, and I'll be. So, okay, so let's talk about it. Because you can't talk about every scenario you might find yourself in. What your choices would do is start a conversation with the to go to that agent and say, okay, we see that you're not advocating. Can you tell us how you're advocating for that? And so what can happen is that we can have someone say, you know what, this is my best friend. She completed this document and maybe it's really crazy that she has cancer. And guess what? She's looking for I'm trying to know that she's been there in remission. And I know that they're trying to for a baby. And I know that she says she doesn't want to be intubated or anything, but I actually don't think she wants to try to be. Okay. You put this understand. Because people can't write every single scenario. However, we can have someone come in and say, okay, do everything, but then, you know, we don't want everything done. And then you can go and say, well, tell, you know, out of town, say, you know what, I think, healthcare agent's going to remove it because he's collecting the checks. Okay, we then can go to the son that I'm keeping him on everything and say, well, it looks like, you know, can you explain to us why you're not doing this? And then if he still goes, oh no, we had a conversation, and I know that he was still scared about this and wanted to do it. We'll still do everything, but we might come out of this time. If you feel like it really isn't, then you need to get ADS in. Because remember, the court is perpetual and that authority. So that helps distinguish some of the differences because we have people, I'll give you really another example quickly of COVID was a big eye opener. People that had said, I don't want intubation, I don't want to change. Oh, wait a minute, she's here for COVID? Okay, actually, I think because so many people did come off ventilators after being on longer than the average time, we do. We had people come in staff during COVID. So it really, it sparked a conversation for us, but then also, this is what I was talking about, we have an committee in the hospital. And part of that is for us to get involved when it looks like, okay, we need more people to say, it doesn't look like you're advocating for your loved one, maybe according to their advance directive, or even if we have a suspicion about one from comments from other people or other families or something. And so we can get the ethics team involved as well. Because we always do. We're trying to do patient one, but I really stress that if you're naming a healthcare agent, it does give them authority. And so these are broad general principles. And because situations can be so different, like with COVID, like with accident, we're gonna trust and we're gonna ask them help to get something under the speaker. Does that help?
Yes, thank you.
I will also say that for anybody that does not have, one second, anybody that does not have a liquor agency that takes for it, you have to go through that legal notice third order. Remember, there's a certain group within there that can't even choose to make someone a DNR, and therefore there's a two-position DNR that requires the, input of the health, of the ethics committee, because therefore we then have to have a committee look at if you can even make someone a two-position DNR. Your questions, sir?
What if you workers pay and they get that benefit care from the state? And they also basically make for these also
Yes.
space. So
Everybody has, everybody to do.
so I get to do what? Well, you can take this piece of paper and just give it to the HR and it's like, hey, this is what I want. Well, of course, doing an open enrollment. These are the
It's not for HR. It doesn't have, it has nothing to do with employee status or anything like that. This is for individuals. An individual completes this, you talk about it with someone that you want to be your advocate, or if you were advocating for someone, you know, if you want to go have a conversation with your mom and you work through those things, then you have her complete it, you get it witnessed, once it becomes a legal document, then if she's ever in the hospital, you would have it as a way of saying, I'm here as her advocate. It gives you the right to advocate for her. Yes.
Of course, it can also be shared with the healthcare team.
Oh, absolutely. We encourage people to upload it in your own.
Plan, care, decision making.
Absolutely, yes. I mean, I'll tell you when we get to the last part of this thing, copies are going to the original. You would then have a copy, you give copies to anybody else that you need to be an advocate. Share it with your medical team, share it with who doctors are, share it with the hospital system that you use. So that, again, if anybody ever finds their loved one there, they already have it to say, you know, that way they know who to reach out to.
Keep it on your ICE plan. And
Well, and that's what's gonna come with the plan. There you go. So then the next page, this,
Can I just ask you to go a little bit deeper into the FHP? Who's on it? When does it come into play? And what authority or decisions do they have?
okay, so I have the members, we've got, I might have to, is in our health system too. Members are physicians, nurse practitioners, we have clinical ethicists, we have clinical workers. Right, they also, but there's also like you have to go through ethics training, the city training and everything. And then they have ethics consults that then is divided out into smaller teams that get involved. So the health system itself is putting in ethics consults on patients. And then they collaborate and make suggestions, and they bring in family and other specialists and things like that. Yes. Yes. Yes, yes, we have risk and legal and, social workers and chaplains, thank you, that's good for you to bring that. I can't, I'm sitting here going, who else is on our ethics committee? We have, community members as well. Because we also always need to be sure that the community understands what we're doing and is a part of that as well, to bring other viewpoints that might be missing. So, yes.
so this committee is established or committee. Their authority is
The authority is that they answer the specific ethics consult, and it is headed by our clinical ethicist, and the authority is as far as within the consult, the committee makes, the team that's assigned to each consult is making suggestions. So they bring in what the legal aspects are, what the social work, we're sure that all the other interdisciplinary teams are kind of having input into what the question is about, what the specific ethics issue is with that payment. You're welcome. The next page, and can you tell me how to do it? Thank you. Okay. So the next choice is about CPR, because when you're in the hospital, the physician comes and it's an order for you to be in DNR, but you're not DNR in the community. And remember, that's where that little asterisk is there that says if you want to be a DNR outside the hospital, that's so that this order of life-sustaining treatment is referenced in there to remind people of that this is a conversation with a physician, and that it's good status for in the hospital. And then in case of pregnancy, we're encouraging everybody over 18 to do this, because this isn't just for, hey, my grandmother needs to do this. Everybody over 18 needs to be considering what their choices are. And if someone has to advocate for life-sustaining treatment, and so there's a part in there about the viable fetus, and you had said that you didn't want life-sustaining treatment, maybe you're having life-sustaining treatment for the viability of the fetus. The next part, has anybody heard of 5 wishes? 5 wishes is another advance directive that's out there. It's good in a lot of different states, but it's really big on comfort measures that I love. And so one of the things that we included was this whole part around comfort measures, because comfort is more than medicine. We do music therapy and pet therapy in the hospital for a reason, because comfort is more than medicine. So, who do you want around? Who do you not want around? I went in to see a patient in the hospital, and the young man sitting next to him that I thought might be his son was his employer. And he wanted to name him as his healthcare agent. And he said, he's going to be my advocate. I'm like, all right, there you go. Family I'm like, all right, let's do this. And we were working through it. We got to the comfort measures of that. This is where you got to advocate for things that people do. You got to tell them what you like. Well, I like that. All right, the employer left. Like, there you go. Now I never have music to play. But this is a big deal. I would say that this is something that I've really encouraged when I say that victim relation is more important. For those of us that are walking alongside someone, we want something. My mom and mother. I've got women I've seen in the hospital through their own nails, but that was important to their mom to keep her nails done. What's the thing or process that give you something that provides comfort that's more than just medicine, right? Then there's also a part around funeral preferences thing. This is not the authority part that was around, making decisions about organization and stuff. This is about, you bought a plot, you plan, do you know who you want to do a service, what you would want done. I've had people tell me I know who's bringing what casserole and who's singing what song. And that's great. They can put all of that in here, and that can help loved ones know what they want. The main thing, though, is that, like I said, part 1 is probably the most important thing is getting the right person. Part 2 is going to give you a good breadth of a conversation around how to advocate. But whether you do part 1 or part 1 and part 2, you have to do part 3 immediately. This is where you sign and you date it. The person that's completing the document. Do not complete this for someone else. The person that's completing the document, meaning they have to be of sound mind. Don't ask me to come to an advance directive with your name. They can complete an advance directive. The person completing it has to be of sound mind. Don't ask for this if you want to do it for your loved ones. Oh, I know they were. No, these are their choices. So they sign and date it. Then you get 2 witnesses. Those witnesses, we go back to, they have to be over 18. They cannot be someone that you've named as your healthcare agent. They cannot be someone who would benefit from your death. So therefore, we really caution people about don't go sit around and do this with family and then have everybody witness each other. Because then someone can come in and go, I don't think so. The whole point about this is to make sure they don't support the we want to ensure that people know. Yeah.
Just curious, do you run conversations with the children trying to meet so that there's the opportunity for their parents or whoever they name to stand in with them with some issue?
Right. So someone who, so for 18-year-old completing the document themselves, absolutely. I still say anybody over 18. And I think that's only because you go spend a day in PD and you'll see everything that wasn't going to be there that day. And so we assume that it's us advocating for our parents, but your parents advocating for you. So understanding that choices around quality of life apply to everybody. Yes.
Shocked the first time. My mom, you feel that it was directly when I was leaving for college.
That's amazing.
The forms available. Age 18 to 60. So, but they're filling it, they're having conversations and
I just had another colleague that works in our health system, and she said, Libby, my son is heading on to college and he's going to play football. And she said the football team just asked us if we had an advanced directive for him. Because at 18, once he's legal, it's like, okay, you need to know that if they're not a spouse and they're not close to 18, they're not going to have an 18, then it's going to automatically do you're leaving the surrogate. So that's why I'm like, well, I know you're not married with children, so, but, what though? Again, 18-year-olds that just have, a 24-year-old in the hospital who has being he was like, nope, that's what you kind because my okay. But he knew what he wanted, and he was facing some really big decisions. So, yes, I think it's really important for everybody over 18 to start having that conversation. Yes, right.
Everything that we talked about is excellent. This is excellent. But all of this is centered on either in hospital or what if somebody's in a car crash? Or what if they're in a store and they murder? How could they make sure that what their wishes are get done?
So, great question. We're getting to, now that I'm at the end of, got to the end of my making it legal. We're going to get into part of it is if something happens in school and you're taken to it would be great if the health system already has this completed and we know the right person to reach out to. Then, well, and that would be fun. Yeah. Now I'm going to get you on the soapbox about having a registry that doesn't exist. But if anybody wants to go with me to the government, I'm taking it, and I would love to do that as well, because I think that the registry statewide for now is incredibly important. For the reason that it's more important these conversations, what do they do if you can follow them? What I will say though is if you do have people that this is where planning can comes in. I'm going to stop real quickly just to remind people that once you sign it and get your witnesses and the legal document copies are included the original, so make copies and give them to as many people as you need. For the person that you want advocating, those backups. People are going to be the problem once everyone calls. They're like, okay, we don't have to listen to you. We've got the right people. When people do update this though, the old one is automatically revoked. If you make copies, you say destroy old copies, but if you haven't, and two people come into the hospital system and they say, we're going by the most recent date because we know that the old one was automatically revoked. But I do want people to remember that that these don't expire. So if people have separate general power for healthcare and living will, they're still good. They don't expire. But think about every decade, the 5 Ps of thinking about when you should leave, do I need to do another one? Every 10 years, when they expire, are these still your wishes? With a death, people that have had their loved one that's passed away, and you've got so many things to go through to change accounts and this and that. Forget they updated their Advance Directive. With divorce, because of that hierarchy status, if you marry someone, you are giving them rights. So when you have divorced the person that you named your healthcare agent, but you still want your ex to be your healthcare agent, you need to rename them, redo your document. In the same way, if you marry someone that's not your healthcare agent, you have to redo that as well. Meaning that it doesn't have to change it. If I named my son as my healthcare agent, but then I went and got married, I would need to rename my son because I just gave someone else a different hierarchy status as a spouse, and I would need to show that I was still constantly choosing my son as my husband. Okay? Diagnosis and decline are the things that we talked about in healthcare that, you need to start having conversations when you get a diagnosis. Decline versus gradually altered every day. These are showing it. Every time I stand up, I'm sitting on the ground. But it's happening to gradually get don't pay attention. So that whole is one way, and that is national, that you can let your choices be known because it's set beyond an advance directive, but it's only for people that are considering their last year of life or people that have a degenerative brain disease like, dementia or Alzheimer's. Bill has me so well trained to say beyond dementia instead of dementia. But this is something that, again, that specifically help people within our state. It's very safe, and every state has their own version of it. But again, one state isn't going to beyond in another state. But then laying the hands where we come to that next part, saying, okay, this, keep your information, travel with it. The medical information, let EMS know what medication, your allergies, your medical history, things like that. But then having a copy, instead of putting the whole advance directive in there, we give out a wellness card within our stuff. So then you have a develop card in here that says, hey, this is the person that speaks for me. I had a person who helped put this folder together, and she fell when she was in New York. And they had who her person was, had all of her history on her, and then she had other things that she like speaking with her for specifically personalized to her. But goes in the phone part of people that take too, because for your home, where does the EMS look for vital information? On your fridge. We can keep this on your fridge and they know where to find it. And they know that this is your vital information that needs to go with you. If you're in a car accident, it's in the medical car. So there's a lot of different things out there, though. They're all do kind of the same purpose. The yellow project, the vial for life, there's the different things are out there. Yes.
Back to the part one on the witness protection. Should or could your advocate be one of the witnesses?
No. Your healthcare agent cannot be a witness. Cannot be a witness nor anybody that could benefit from your death, specifically not your healthcare agent. Yes.
The person who is four signs, and then two witnesses, but the person who's being named
Does not be signed. So that's really we're going to go back to the conversation more important because guess what? The person who is named, if they don't know their name, they have the right to refuse. So they don't have to sign it saying they're accepting it, but I'm telling you, you better let them know because again, we called on people and said, hey, Ms. Smith here in the hospital, we see that you're named as her healthcare agent. And they said, what? I didn't know that. I don't feel comfortable making a decision, so they have the right to refuse. So, and they know. It's great to have a secondary, but it's really, for the people I love that the lawyers out there doing this in a package of doing a will and a financial power attorney and advance directive together. But the point is that for people that keep it in their lawyer's office, it's like, or they did it with their lawyer and did it and then never told the people that they need. It's like, hey, conversation is really very vitally important. So the whole point was to remember there were victims. You've got people that were fighting for rights for both sides. We've got the death and dignity group that's actually now made medical assistance in dying and coming before the Senate again. It's going before the Senate twice is the death with dignity bill. And it's people saying, you know what, these are my choices. And I'm all about people that are, it's about your choices. So they're saying this is independent states that do have an aid bill, or state is going to be looking at it in 2025. But there's also the not dead yet. You don't have to be, I don't want to be with positive mindset, because you know what? No matter what, you can be on a ventilator, you can be in a wheelchair, you can be on whatever machines it is, and I choose what positive mindset is for me. So there are pendulums out there, because people advocating. It's all about patient system. It's all about how you advocate for what you love. So we go from, we're trying to move people away from me. I'm not ready, to this really sweet family up in Gainesville, Gordon family. So he did us the time of the conversation with us, because we were able to just walk what he said. We didn't have to make decisions for him. We just got to walk what he said. So we start off with Mandela. Country song. We all get our knowledge from country music, right? And Rob, I didn't try to tell. Someday I'm going to get a chance to live like you. The whole song. Someday I hope you get the chance to live like you were going. Because it doesn't talk anything about how you die in the song. It talks about how it changed my personal life. Got to ride, into. But you know what? He talks about fish more with my dad. Of time or people. The whole premise of the song is not that God changed the name, it changed my soul. I really feel like the biggest thing that I stress to people is that there's a lot of stuff, you know, pieces and parts, you know, and choices. But the biggest thing is that, you know what, be privileged. I don't have an advance directive because I have a steering, but because I have a family. So you have